short class on intrahepatic cholestasis of pregnancy. It is defined as otherwise unexplained pruritus with abnormal liver function tests or raised bile acids. Generally, since bile acids is an expensive test, a lot of diagnoses clinically are made only with the presence of pruritus and abnormal liver function test, which includes raised SGOT and SGPT. Both should resolve. The pruritus and abnormal liver function test or raised bile acids should resolve after delivery. And this doesn't include the definition, but the characteristic feature of the pruritus is that it starts in the palms and soles and progresses to generalized itching, and they'll finally complain of a lot of itching on their abdomen. Now, when there is a female with abnormal liver function test, itching is a common complaint during pregnancy. It can be because of IHCP or it can be because of other factors. But whenever there is abnormal liver function test, you have to rule out other causes of liver function test abnormalities like hepatitis infection, autoimmune conditions, liver ultrasound. Consider preeclampsia, AFLP help also if she has hypertension. So LFT, deranged LFT with itching will not be labeled IHCP if she has HELP syndrome. This distinction you have to make. So this depends a lot on the clinical presentation. If nothing else is there and it is pruritus with abnormal LFTs, it is IHCP. So IHCP or ICP is a diagnosis of exclusion. Pathophysiology, unlike the common belief, it is not associated with diet. You're not supposed to advise any dietary restrictions. It is genetic, hormonal, and some environmental factors plus minus are there. Genetic susceptibility means hormonal changes are going to be there in all the pregnancies. All the pregnancies will have very high levels of estrogen and progesterone, while only some women will have intrahepatic cholestasis of pregnancy. The hormones, this is because of genetic susceptibility. The hormones involved are, of course, estrogen and progesterone. Women who have ICP during pregnancy might also have same findings while taking OC pills, which have high dosages of estrogen or even progesterone. Estrogen may induce cholestasis, that is one pathophysiology. Progesterone sulfate metabolites alter hepatobiliary transport system by impairing the function of hepatic bile acid receptors. So because of both of these mechanisms, there is spillage of bile acids in blood and bile acid levels are higher. Environmental factors against the common belief, it is not high fat in your diet, high protein in your diet. These dietary abnormalities may be associated with abnormal LFTs outside of pregnancy, but if the abnormal LFTs are because of intrahepatic cholestasis of pregnancy, it is not associated to diet or any supplementations like proteins or iron or calcium. It might be because of selenium and vitamin D deficiency. Very little evidence is there for all of these pathophysiologic factors. Lab findings, bile acids more than 10 micromole per liter. Do fasting bile acids because it is affected by food. If the bile acids are more than 40, it is an indicative of fetal risks, increased fetal risks. Aminotransferases, SGOT, SGPT are moderately elevated, and rarely they might even go above 250. So generally they'll be in the range of 35 to 250. Bilirubin, infrequently. So rise in bilirubin is also infrequent. If these things are there, the aminotransferases are very high, bilirubin is high, you have to necessarily rule out other causes of abnormal liver function tests. Pregnancy outcomes, there can be preterm birth, there can be stillbirth, meconium passage, increased labor induction, of course, because you have to induce a 37 to 38 weeks, fetal distress and respiratory distress, fetal distress during labor and respiratory distress or birth asphyxia in the neonate may be because of intrahepatic cholestasis of pregnancy. These are high-risk pregnancies because of the fetal outcomes. Maternal outcome is not much affected. Management in pregnancy, once you've diagnosed ICP, you have to follow her up with LFTs plus minus bile acids every 1 to 2 weeks. So every week LFT should be measured. For the itching, you can give antihistamines or topical emollients. Ursodeoxycholic acid may be given in a dose of 300 to 600 mg twice daily. It does not affect the obstetric outcome. It does not improve the fetal outcomes. It might help just with the itching and with the liver enzymes. It will not improve it will not decrease the chances of fetal risks. Vitamin K may be given if PT is prolonged. If liver functions are deranged so much that the PT is prolonged, then you can give vitamin K during labor, starting from 3 days before labor. Antenatal surveillance, though there is increased risk of meconium, stillbirth, respiratory distress, all those things, it cannot be predicted by any form of antenatal surveillance. There is no fetal growth restriction. So Fetal growth restriction is a separate diagnosis. IHCP does not increase the risk of fetal growth restriction. So ultrasound surveillance or CTG surveillance does not help much in deciding the time of delivery or improving the fetal outcome. No specific method of antenatal monitoring has been recommended. Continue during labor, since there is a high risk of respiratory distress, you can continuously do fetal monitoring. Delivery recommendations, very simple. If the bile acids are more than 40, according to RCOG, the delivery should be at 37 weeks. ACG, American College of Gastroenterology, recommends delivery at 37 weeks irrespective of the bile acids once you've made a diagnosis of IHCP. ACOG also says the same thing, 36 to 37 weeks you should deliver. Postnatally, after delivery, you have to repeat LFTs to ensure that the liver enzymes have come back to the normal levels. Postnatal resolution has to be confirmed. This has to be done at least after 10 days, ideally at 6 weeks. Do not do it before 10 days. If the patient is worried, do it at 10 days. If the IHCP was not much, you can do it at 6 weeks also. And if it is shown to be resolved, it is IHCP and a resolved IHCP.